Well, as Dennis said, an hour and a half is not very long to talk about radiology, because as a radiologist, it's my favorite topic, and I tend to be a fairly quiet person until I talk about my work, and then I can go on forever. So I'm going to look very carefully at the time remaining to me, because I can drone on. I know that a lot of you have attended TMJ courses, and the presenters will talk about images, and they point out a few things on the images, but you don't get a lot on radiographic interpretation. So that's my purpose today, to give you a little taste of the sorts of things that we look for. An hour and a half is certainly not long enough to cover everything that occurs in the TM joint, but I want to focus on some of the more common conditions, and also take a step back and talk a little bit about the different imaging modalities that you have available to you to look at the temporomandibular joint. When do we image TMJ patients? And these are guidelines that have been published from a variety of papers, and I've just consolidated them here. Pain which is unresponsive to conservative treatment. In other words, that sentence is implying that you've already tried some treatment without any imaging. You as the clinician are responsible for that patient, and it is your professional opinion or your professional decision about whether to send a patient for imaging right at the beginning or to wait. And I think in many cases, if you have patients coming to you with pain, your clinical examination is only going to give you part of the information, and that imaging for most of these patients is indicated. Trauma, obviously. Significant dysfunction or alteration in ROM. ROM is range of motion. Sensory or motor alterations, significant changes in occlusion, and swelling or soft tissue mass. We're going to come back to that at the end. If you ever have swelling over the TMJ, especially if it's painless, you've got, that is a sign that something else may be going on, and we're going to talk about neoplasms at the end of the talk. Now, there are some medical legal aspects to imaging which I want to get out of the way right from the beginning, because oftentimes people forget to talk about this. So let's go back to basic principles of imaging. What sorts of images do we need when we're evaluating our TMJ patients? Some kind of a panoramic view. And notice I say view, because it can be an actual panoramic radiograph that you take with your pan machine, or it can be a reformat from a CT scan, a panoramic reformat. I'm going to talk about that a little bit, but some kind of panoramic view to show the jaws, and I'll tell you why in a minute. We'll come back to that. You also want to view the TMJs in the sagittal, also known as the lateral, and the coronal or frontal directions. That's as a minimum. Basic principles of radiology and medicine, if you break your wrist, they take a view straight down like this, and then they do a view at 90 degrees. You've heard that before. In radiographic imaging for the jaws, we talk about doing a periapical and then an occlusal to see if they're swelling, that sort of thing. You always want a view at 90 degrees, and that's what the lateral and frontal views are going to do for you. You cannot have one and not the other. I know in the past some people were only doing lateral views of the joint. It only gives you half the information, and I'll show you that with some illustrations later. Then, depending on the patient's history, you may want some cephalometric views, and you may want a cervical spine view, which unfortunately I don't have a lot of time to go into today. See, I need a day, Dennis. Give me a day. So, the panoramic view. I think we can all agree that panoramics have limited usefulness for looking at the TMJs. Why is that? It's a distorted image. The patient is improtrusive. Do you know why they're improtrusive? They bite on the little stick. So a lot of you may or maybe may not be familiar with medical CT units. Some of you may have had a CT scan done in a hospital. Generally speaking, on those scans, the beam, the X-ray beam, is very, very narrow from front to back. The patient is lying on a table. And the beam is wider at the bottom than it is at the source. And this is called a fan beam. Not the kind of fan that cools you, but the lady's fan, okay? So it is very narrow from front to back. So if we're interested in imaging the entire head, the beam is narrower than the head. So what do we have to do? We have to take multiple images of the head. And that's what actually happens. The beam will spin around the patient really fast, and the table moves as it's spinning. So we slowly, eventually, we image the entire head, usually from top to bottom. So these are two different patients, same patient. This is one patient on the left side and a different patient on the right side. And this is typical of what we see with advanced degenerative joint disease. This is done in the closed position, and we see the very narrow joint space. There's still a joint space there, but obviously no room for a disc. You can imagine what's going on with the disc. We can guess it's down here somewhere. Look how radiopaque the temporal component appears, and also the condyle is very radiopaque. And we've got these dark areas in here, and it's interesting, it looks like there's 4 holes here, and another one. These are subchondral erosions. Some of the books call these Ely cysts, named after the person who first described them, E-L-Y, and they're not a true cyst. Remember, a cyst is a epithelial-lined cavity filled with fluid. They're not a cyst, but they're called a cyst because radiographically they are very round, radiolucent, and well-defined. So they look cyst-like in a radiograph.